I'll be speaking on CRPC and specifically new combinations of AR pathway inhibitors, and these are some of my disclosures. Looking back, the androgen receptor pathway inhibitors, these more powerful suppressors of androgen receptor signaling, were initially developed as monotherapy, of course, first post-docetaxel and then pre-docetaxel in the Cougar and Affirm and Prevail studies. And I'm old enough to remember a time before these drugs were available and literally can see the faces of some of my patients who died waiting for these drugs. They've made a huge difference, significantly prolonging survival and improving quality of life as well as quantity of life by really being effective at cancer control. Next came along apalutamide and darolutamide. They were studied in non-metastatic CRPC, and then all four of these agents moved forward to metastatic hormone-sensitive prostate cancer, where we saw their significant benefits even further amplified. However, as that has happened, what makes a castration-resistant prostate cancer patient's disease tick is also impacted. And most of our patients with mCRPC have been exposed now to doublet or even triplet therapy. Hopefully they're getting intensified therapy for mHSPC. And that makes them different than the populations in the studies that I'm going to talk about today. The majority of these studies were really done in the absence of prior exposure to androgen receptor pathway inhibitors. And the disease is different, at least in some patients after exposure to androgen receptor pathway inhibitors. We get specific mutations coming about. We can get even androgen receptor indifference or some more aggressive behavior. So that does make it challenging to apply the findings of these studies to the patient populations that we're seeing in clinic. Nonetheless, these are important studies and are finally moving us out of a single sequential strategy, which has been our dogma for a long time. So we'll go through these. First, the PARP inhibitor studies, and then the radium-223 study, piece 3, which was presented at ESMO last year. PROPEL was a study of abiraterone with olaparib or abiraterone with placebo in patients with mCRPC, all comers. So once they were enrolled, NGS was performed to identify any HRR alterations, and you can see that it was close to 30% and well balanced between the two arms. PROPEL was positive for its primary endpoint of rPFS in all comers. However, the magnitude of the benefit is different. If you look at patients with a homologous recombination repair alteration, on the left, there's definitely a greater separation of the curves than patients without a homologous recombination repair alteration. So the FDA approval was actually restricted in this case to patients with a BRCA alteration. Magnitude was abiraterone with niraparib or abiraterone with placebo in mCRPC. Again, first line, no prior exposure to AR pathway inhibitors. This trial was run differently in that the genomics were known ahead of time and patients were placed into cohorts, either biomarker positive or biomarker negative. So magnitude was also positive for its primary endpoint, but only in the cohort with HRR alteration. Actually, that second cohort that did not have any HRR alteration had to be closed for futility. So the results we're seeing were only patients with a mutation that should sensitize to PARP. And here you see that patients with a BRCA mutation had the greatest amount of benefit compared to patients with the other HRR alterations, but the study was positive. FDA approval was for patients with BRCA alteration. And finally, we have TALAPRO-2. This is enzalutamide with talazoparib or enzalutamide with placebo. The talazoparib dose has to be reduced compared to what's used in monotherapy, which is similar to magnitude. The niraparib dose had to be reduced as well. So this study took all comers, but then did look at the genomics, so similar to the design of PROPEL. And you can see on the top, all comers, there is a significant improvement in rPFS, hazard ratio of 0.64, but it is stronger in patients with a homologous recombination repair alteration. It's 0.46 in that setting. So definitely a greater magnitude of benefit. And the approval came through for HRR alteration, mCRPC. So questions remain. First and foremost, a patient who's progressing on abiraterone or enzalutamide or apalutamide or darolutamide, would they benefit from this combination? And we really just don't know. And so for those patients, I would do the NGS, but probably select PARP inhibitor monotherapy. Is combination better than sequence? A lot of people wonder whether similar outcomes could have been achieved if patients crossed over. I think the Brackaway study presented by Maha Hussein shed some light into this question. She did track patients who got abiraterone followed by olaparib, as well as patients who got olaparib followed by abiraterone versus the third arm, which was the combination of abiraterone and olaparib. And the combined rPFS is more than double in the combination arm, suggesting true synergy. It's not just that you get benefit from each drug independently in sequence. Are there populations who shouldn't be exposed to these AR pathway inhibitor, PARP inhibitor combinations due to a perceived lack of benefit? Well, certainly we're learning that not all HRR alterations are as good at predicting benefit from PARP inhibitors, whether in monotherapy or in combination. This publication last year in JCO from a pooled analysis that was performed by the FDA looking at all of these PARP inhibitor trials finally allowed us to have enough numbers of patients with these less common HRR alterations, such as CDK12 and CHEK2. And we can see that there are truly differences. So I encourage you, when you encounter one of these alterations, if you want to counsel a patient what the likelihood is that they'll benefit from PARP inhibitor therapy, either in mono or combination, then reference this paper. But generally speaking, ATM seems like a group that does not necessarily benefit much from PARP inhibitor therapy. Same with CHEK2, although CDK12 and PALB2 still look good. So again, it's very helpful manuscript with a lot of useful information. In terms of side effects, the main side effect across the board is anemia. It ranges from 46 to 66%, and some patients will have grade 3 and will require transfusion. So that's something we need to talk to patients about when we're considering this combination. It's definitely more than what we see with an AR pathway inhibitor alone. There is some potential for nausea, anywhere from 21 to 31% as well. However, other than that, there weren't really new toxicity signals that emerged. There is a slightly higher rate of pulmonary embolus and other VTEs in the combination groups. So that's something to just have an elevated index of suspicion for. And with abiraterone niraparib, there was a higher rate of arrhythmias and hypertension, maybe because of the drug-drug interaction augmenting those toxicities that we attribute to abiraterone. Patients do worry potentially about things like AML, MDS. Those rates have been really low across all of these studies, which is very reassuring. In TALAPRO-2, there was one case of AML, one case of MDS, both on the talazoparib arm, but we'll continue to look out for those events. So there's some toxicity, but overall really not dose limiting or unmanageable, I would say. In my practice, I'm able to use these combinations. And importantly, in TALAPRO-2, they did look at quality of life. And quality of life was similar in the two groups and actually preserved over the longer term, which is likely due to better cancer control. So cancer symptoms really drive a lot of the deterioration in quality of life of our patients with CRPC. Could be different in biochemically recurrent and other settings that we've talked about at the meeting. Moving on to piece 3. So this was a study of enzalutamide with radium or enzalutamide without radium. This was in patients with mCRPC who had at least 2 bone metastases. They didn't have to be symptomatic, which makes this trial different than the ALSYMCA trial, which was the registrational trial for radium-223. And radium was given at that same dosing of once a month for 6 doses. So this trial was positive for the primary endpoint of rPFS, but also significantly positive for overall survival, which I think really was striking. And many people found this to be one of the most important pieces of data presented at ESMO last year for prostate cancer. Patients could have received prior docetaxel in the hormone-sensitive setting, but again, these are not patients who received doublet therapy, so they were not patients progressing on an AR pathway inhibitor, which can limit the application in our practice. Why was this trial positive and not the ERA-223, which was abiraterone with radium in a similar randomized design? Well, piece 3 actually learned from ARA-223. So in ARA-223, they saw increased risk of bone fractures. And it was not in the presence of metastases, but rather they were insufficiency fractures, like osteoporosis type fractures. And one might speculate whether prednisone 5 milligrams BID contributed. That's the dosing that we use with abiraterone in the CRPC state. But it also could just be due to low use of bone supportive agents. And in fact, when piece 3 saw the ARA-223 fracture data, they stopped their trial, mandated bone support, and because of that had a much higher rate of utilization of bone support. The majority of patients in that trial received it, and they had a much lower rate of fractures. So if any of you have seen an elderly frail patient have a hip fracture, that sometimes snowballs into a series of events that can lead to death, and you understand why we think fractures could have contributed to the difference in the piece 3 trial being positive and ARA-223 not. So bottom line, always use bone support, either denosumab or bisphosphonates, when you are treating patients with radium-223, whether alone or in combination with an AR pathway inhibitor. But this piece 3 data is intriguing and raises the question of the synergy of AR pathway inhibitors with radioactive treatments. And would an AR pathway inhibitor enhance response to lutetium PSMA type treatments? In the VISION trial, standard of care was an AR pathway inhibitor and was used on both arms, so combination was used. However, on therapy, which compared lutetium PSMA to cabazitaxel, they were not used. So you can use lutetium PSMA either with or without an androgen receptor pathway inhibitor. And there's reason to believe that there could be impacts because AR expression and signaling impacts PSMA expression and cycling of cancer cells, which could impact the response to the radiation. In this retrospective analysis published last year, there was found to be an advantage to patients receiving the combination. But of course, this is only hypothesis generating. These patients maybe had inadequate exposure to AR pathway inhibitor or other reasons. Prior androgen receptor pathway inhibitor therapy, in fact, was prognostic, so that's probably part of the reason. But I think this is a question that academics are going to need to set out to answer. I'm not sure industry is going to do the trials that will help us understand how to best utilize these agents potentially in combination moving forward. There are other novel agents that are being studied in combination with AR pathway inhibitors. We have the bispecific T-cell engaging immunotherapy antibodies, such as AMG 509, which is CD3 and STEAP1 targeting. This is now known as xaluritamig. And in the phase 1 study, there's a cohort with enzalutamide combination and a cohort with abiraterone combination. Definitely seeing interesting results, but I can't speak too much to them, but eventually they'll come forth. The phase 3 is being done as a single agent, AMG 509. But the HK2 targeted bispecific from Janssen is also studying an AR pathway inhibitor combination cohort. EZH2 inhibitors, CXCR1, 2 inhibitors seem to be agents that may need to be combined or may benefit from that combination. And then our friend Ed Posadas, who presented on Sunday, has a trial of apalutamide with or without carotuximab, which is an endoglin antibody that preclinical studies suggest will augment the efficacy, specifically in patients with prior AR pathway inhibitor exposure. So that's a group we really want to augment the efficacy of a second AR pathway inhibitor, since it's not a very effective strategy to do that switch on its own. And then the AR PROTAC degrader is this novel chemistry that targets AR, but through a different mechanism, but seems to be more effective in the context of a ligand binding domain mutation and slightly less effective for wild type AR. So using it together with the AR pathway inhibitors makes a lot of sense potentially, although some of the newer agents may not need that. So in conclusion, for patients who develop mCRPC off of doublet or after triplet, we don't really know whether we should be using combinations of AR pathway inhibitors with PARP inhibitors or the piece 3 regimen. But if they have not, then certainly these are strong data, level 1 evidence phase 3 trials. So we need to be doing genomic testing to identify these patients and offering them either PARP inhibitor monotherapy, or if they're CRPC without progression on AR pathway inhibitor, the combination. Some of us feel like the enzalutamide radium in a patient with a heavy bone burden who's progressed on ABI could be considered, but truly that is not the population that's represented in the study, and we don't know that they would experience that same benefit. So those progressing on the AR antagonist, certainly we don't know anything about. Combinations, we're using single strategies like chemo or radioligand therapy in those patients. Thank you so much and enjoy the rest of the conference.